In this case, during the injection of this preloaded single-piece acrylic IOL, the patient suddenly moved his eyes and the IOL hit the posterior capsule, causing a rent. Since this was a single-piece IOL and the rent large, it had to be explanted. Viscoelastic was injected to plug the area of PC rent and to lift the IOL from the back. Using a Sinskey hook, the IOL was dialed out of the back. During all these maneuvers, it is important to fill the anterior chamber with cohesive OVD to create enough space to protect the endothelium and posterior capsule. The corneal tunnel was extended slightly and the IOL was held at the haptic-optic junction and was folded and pulled out of the eye. OVD was again injected to seal the area of rent. Visco didn't appear to go into the vitreous, which gave a clue that the anterior hyaloid face was intact. A 3-piece foldable lens was injected into the anterior chamber, and the haptics were carefully dialed just under the iris over the rhexis margin. Now the optics were taken under the rhexis margin and captured. This is indicated by the round rhexis taking a spindle shape. It is better to avoid injecting the IOL directly under the iris, since sometimes it can go under the rhexis margin, in which case it can drop into the vitreous. Pilocarpine was injected to constrict the pupil. Pupillary peaking became evident, indicating the presence of vitreous strands, which was confirmed by injecting triamcinolone acetate. Anterior vitrectomy was done. Both the cutter and the irrigating cannula were introduced to the side ports, which should be snugly fitting, and we need to use the highest cut rate that is available with the machine. Completion of vitrectomy was confirmed by injecting triamcinolone acetate again. Intracameral moxifloxacin was injected and the side ports were hydrated. In the second case, on the first post-op day, one of the haptics was found to be broken and was in the anterior chamber. The 3-piece IOL was descended. After forming the anterior chamber with OVD, the broken haptic was taken out to the side port. Cohesive OVD was injected under the IOL and it was dialed out of the capsular bag. A single-piece foldable acrylic lens was then injected into the bag, since this can scaffold and protect the posterior capsule. During this maneuver, enough OVD was injected over the 3-piece IOL to avoid unnecessary rubbing of endothelium. While cutting the optic, the second haptic also came out. A dialer was used to stabilize the IOL. Since it may be difficult to bisect it in one go, half of it was cut step by step using a long Vanner scissors to the main wound, keeping an eye on the rhexis margin and the posterior capsule. The half-cut optic was pulled out using the corneal incision as a fulcrum. There was a small iris prolapse which was reposited carefully. OVD was removed and the side ports hydrated after making sure that all is well. Here, during the injection of this hydrophobic acrylic lens, the trailing haptic got broken, which was realized only after insertion. The lens was dialed out of the bag, held by the haptic without applying too much force, and was bisected into 2 pieces in a step-by-step manner as described earlier. Here again, the key is creation of enough space by filling the anterior chamber with cohesive OVD like sodium hyaluronate. Then each of these pieces was pulled out of the eye and another single-piece hydrophobic lens of the same power was placed in the bag. These cases highlight the importance of meticulous IOL loading technique and careful injection. Whenever IOL is unstable, we need to fix it or replace it. Key is to keep the anterior chamber pressurized with cohesive OVD to protect the endothelium and the posterior capsule throughout the procedure. Ideally, we must have a backup 3-piece lens in all cases because surprises can happen at any time.